In this video, we'll be going through some of the answers to the questions that I posed in the previous video when talking about renal failure in patients with COVID-19 disease. If you remember from the last video, we talked about causes of pre-renal failure, renal failure, and post-renal failure as it pertains to COVID-19 disease. And it's important to think about how we can diagnose the different things because they're treated differently. It's also important to think about the different diagnostic tests that we can do, because with those diagnostic tests, that's exactly the way in which we can tailor the treatment to the specific patient that we have in front of us. So, what we'll talk about in this lecture is the different diagnostic tests that we can use to diagnose pre-renal failure, intrinsic renal failure of the kidney itself, and post-renal failure. And these are real tests that we do on patients in hospital as part of our workup to try and work out why they've got kidney failure. And if they have that kidney failure, then how can we best treat them? Let's think a bit about pre-renal failure. If you remember, pre-renal failure means that there's not enough blood getting to the kidney itself. So one of the simplest things that we should think about is, are they dehydrated? Then we need to think about the blood itself. Is there enough blood flowing to the kidneys? Is the heart pumping enough? Is there a blockage in the blood vessels themselves? Is there inflammation of the blood vessels, reducing the caliber of the blood vessel and therefore reducing the blood flow? Is it that the blood vessels themselves are getting blocked up by blood clots and therefore reducing the perfusion to the kidneys? And as part of all of that, when you're thinking about the kidneys, you always have to think about the heart. Is the heart functioning properly? And is there enough blood getting to the different organs, in this case the kidney specifically? One of the simplest bedside tests we have to assess the heart is a blood pressure. And this simply tells us the pressure of the blood that's coming out of the heart. The higher the pressure, the more perfusion there is to different organs. And the kidneys are very sensitive to that. If the blood pressure drops, then the kidneys will work on producing hormones like angiotensin that'll then cause the blood vessels to constrict and try and increase blood pressure. If the heart, however, is failing, if the pump isn't working so well, then the pressure of the blood coming out isn't going to be as high. Or if you've got patients that are very dehydrated, again, there's not enough blood volume there to create a pressure inside the blood vessels. And so by giving fluid to those patients, you may well be able to increase their blood pressure. Now, blood pressure itself is a surrogate. It's a way of trying to work out the cardiac output. The cardiac output meaning the amount of blood that the heart pushes out per minute. And there are much more sophisticated ways of doing that. So if we want to assess how good the heart is functioning, a direct visual way that we can do that is something called an echocardiogram. Basically, what this means is that you put an ultrasound probe on the chest and you see a picture of the heart, and you see something that looks a little bit like this. And what you're seeing here are the different chambers of the heart. You can see here the left atrium, the left ventricle, the aorta coming out there, and a little bit of the right ventricle. And then you can do multiple different measurements using the ultrasound to assess the blood flow. By putting a little scanner here, what you can do is look at the amount of blood that's flowing through that at a given time. And that's what we're measuring here, is the velocity of the blood as it flows through the aortic valve. And by measuring that over a period of time and knowing the diameter of the aortic outlet, you can then work out the amount of blood that's flowing through. This is a simple bedside way of measuring cardiac output. But there are much more sophisticated methods of measuring cardiac output. If you've ever seen pictures of patients in intensive care, you'll see them with lines in their neck. One of those types of lines is a very special line that you see here. And what this does is it goes through the blood vessel, so the internal jugular vein, down into the superior vena cava, into the heart, so this is the right atrium, up through the right ventricle, and then sits in one of the vessels, the big arteries in the lung called the pulmonary arteries. And what this can do is it can measure the flow of blood going through here and then going through and out into the pulmonary arteries. And whatever blood comes in and out through the right heart has to be the amount of blood that comes in and out through the left side of the heart. Otherwise, if say 50 mils of blood comes out of the right heart with every beat, but only 20 mils comes out of the left side of the heart, that means you've got 30 mils of blood somewhere. And where does that accumulate? Well, it'll either accumulate in the lungs, or it'll accumulate in the heart, and it just becomes more and more dilated on the left side. So the amount of blood coming out of the right side of the heart equals the amount of blood coming out of the left side of the heart. And with this, the pulmonary capillary wedge pressures, you can try and work out partly how much blood is coming out of the heart, and therefore work out a cardiac output. If the amount of blood coming out of the heart is too low, then we need to give medications to try and increase how hard the heart beats and therefore increase the amount of blood coming out of it. There are various other ways of trying to measure cardiac output. We won't go through them all here, but suffice to say, it's really important to try and work out heart function. Blood pressure is a simple bedside thing that we can do, and you see that on every ward, and that's why we're measuring people's blood pressures. But you can also look at more sophisticated things, like doing an ultrasound of the heart, called an echocardiogram, to visually look at the heart and to measure some flows. Or the gold standard is to put in this big long line that sits in the heart and in the lungs, and it just measures the amount of blood coming in and out of the heart itself. We mentioned that one of the common causes of patients who are very unwell developing kidney failure is that they are dehydrated. Well, the simplest way to try and work out whether a patient is dehydrated is to give them a fluid challenge. And so you often see patients in casualty, or on TV you see it, when people come into hospital, they have an IV drip put in and they get given lots of fluids. The reason we do that is we think, are these patients dehydrated? If they are, if we give them fluid, their blood pressure should increase, their heart rate should drop, and their cardiac output should increase. And all of those things should theoretically be good for the kidneys, because by increasing the blood pressure, increasing the cardiac output, you're going to improve the amount of blood getting into the kidneys, and therefore you're going to improve the filtering ability, and therefore reduce the amount of renal failure by getting rid of more toxin. Now let's think a little bit about the intrinsic kidney itself. So if you remember from the last talk where we talked about if you look at the actual glomerulus, it becomes inflamed and infiltrated by lots of white cells, because the white cells are seeing all these cells that are full of virus, and so it wants to try and destroy them. Well, how do we work out whether those cells are being destroyed or not? Whether it's a problem with the kidney tissue itself? The simplest way would be to have a look at the kidney and to take a biopsy of it, to take a sample, look under the microscope and see whether there's any inflammation there, similar to the histology picture I showed you in the last lecture. But that's got lots of problems involved with it. You're sticking a big needle into a patient's tummy. If the kidney was fine before, by taking a biopsy you could cause scarring, bleeding, and also potentially infection. And all of these things are really bad for the kidney, which is already not working well. So it's rare in the acute setting that we do biopsies of the kidney, because actually we've got other ways to have a look. One of the simplest things that we can do is a urine dipstick. This is where a patient passes some urine and then you dip it and you have a look to see what's in it. Normally, in urine, there shouldn't be any protein because all that's happening is that the capillaries themselves sieve out all of water, the plasma in the blood, but it keeps all the protein inside the blood vessels. If, however, the blood vessels are becoming inflamed and damaged, then you can start to get leaking of protein into the urine. So if you start to see protein in the urine dipstick, you've got to be worried. You can also look for signs of infection. If there's white cells, if there's something called nitrites in the urine, again, it indicates either inflammation or infection. And if there's infection there, by treating with antibiotics, you should be able to get rid of that infection. So the urine dipstick, looking for protein and white cells, is important because it'll show that the kidney parenchyma itself is damaged. You can also look under the microscope. And looking under the microscope, you can see a variety of different things. You might be able to see bacteria, and if you've got bacteria there, then you know that you've got an infection. Or you can see something that looks a little bit like this. These are called casts. And what this is that the kidney itself is starting to get damaged up. The tissue inside the kidney is all damaged. And just like with a scab, it then starts to break off, and where it breaks off into is into the urine. And so you see these effectively scabs, which are just whole clumps of cells of the kidney itself that have come out, and they're called casts. And if you start to see casts, then you've got to think, actually, is there intrinsic damage to the kidneys? You can also see red blood cells. You might be able to see one just there, just here. And the urine dipstick itself can also detect red cells as well. So if you've got that, then it means that the kidneys inside are being really inflamed and maybe even bleeding a little bit. And all of these things indicate inflammation of the kidney and therefore an intrinsic cause for the renal failure. Finally, we thought about post-renal failure. This is where you get blockage of the drainage of the kidneys into the bladder. And this can cause back pressure in the kidneys. So how can you detect that? Well, the gold standard, easiest way to do it is something called an ultrasound. And what you do is you have a look at the kidney and you're looking here at the collecting ducts. This is the pelvis. The renal pelvis should be just a sliver, just a line. But can you see here how it's starting to get dilated because there's a blockage around this part here? And so you get slight dilation because all the urine is still being produced by the kidney. It's filling up this space, but it can't go any further, so it just starts to fill up. And so you can get normal kidney here, and then with that blockage, it starts to get more and more and more filled up. And so can you see how this is starting to get more and more dilated? This black here is urine. This here, you can see the border of the kidney here. And this is the, can you see this is all filled with urine? And that bit is the same as what we're seeing there. And as time goes on, it just becomes more and more filled up. And you can imagine that back pressure is a high pressure there. So it's going to be pushing on the cortex and stopping it from filtering out any more blood. So an ultrasound is fantastic, but there are other ways to do it as well. You can do an X-ray where you inject contrast into the vein. That then gets filtered out of the kidney and it tries to excrete it. So you can see here the left kidney where it's filling up and it's being excreted out. So it's not sort of swelling up at all. But on this side, can you see how this is just all swollen up? Because there's all of this back pressure and all you're seeing is all of the contrast filling up this area and not being able to go any further. So you can see how much what we call hydronephrosis or blockage there is on the right kidney, which is just completely filling up. You can also do it with a CT scan. And the nice thing about a CT scan is that you get a three-dimensional picture. You can see here the normal kidney. This is the tissue of the kidney, and this is the renal pelvis. And you can see that it's nice and small. Compare that to what you see here. Again, they've injected IV contrast, and it's just all accumulating here because it can't actually come out and go into the kidney. So this is a hydronephrosis, and this is on the right side. Thinking back to that 59-year-old man who came to A&E and was having fevers, hypoxic, and had evidence of renal failure, how do you investigate them? Well, simply, you do the blood tests that confirm that there's lots of toxins in the body, so they've got renal failure. You do a urine dipstick. You look to see whether there's any red cells or white cells or infection there, causing an intrinsic renal failure. You look at the culture looking for bacteria. You look under the microscope to see whether there's those casts there. You do an ultrasound of the kidneys to look to see if there's any blockages there. And then you do the physical assessment to see whether the patient's dehydrated or the heart itself isn't functioning well. And with all of those things, you can pick out most of the causes of renal failure. And if the patient's dehydrated, you give them fluids. If their heart isn't pumping so well, you can give them special medications to make their heart pump that much harder. If they've got a blockage, you can pass small stents in to open up the ureters and help the urine to drain out. If you've got blood clots, you can give them anticoagulation to try and break up those blood clots and to stop more ones from forming. So you can see that by diagnosing these things, you can really start to tailor the treatment. However, in a number of patients, you will not be able to get the kidneys better until the infection itself is gone. And the SARS-CoV-2 virus, COVID-19 disease, takes weeks to get better. And you can't wait weeks for the kidneys to start working because you get accumulation of toxins and bad salts like potassium. So, what we have to do is to replace the kidney function with something called a filter. And what a filter does is it takes the blood out of the body, it removes all the toxins, and puts the blood back into the body nice and clean. In the next series of talks, we'll talk a little bit about how those kidney machines work, and how we use them in intensive care, and why we sometimes give them to patients, and why sometimes we don't need to use them.